Lovely. We're here with Dr. Naomi Whittaker, and I am just so pumped to get in today's conversation. We're going to really be talking about mostly endometriosis. And Dr. Whittaker, you have so much specialized education, hands-on surgical experience, continuing your credentialing in your work and learning in your personal life, which we were just talking about a little bit before we jumped on. I love. And really such a powerful story fueling your passion to get women answers. So I want to really just dive in. We have a lot to cover, and I know we're just going to be kind of hitting on so many important topics. But the one thing I want to say this that I admire you so much about the work you do is the art in which you do it with. I think that you bring in such a personalized approach. You're seeing the person in front of you, not just treating numbers on a page and not just throwing out statistics at women and talking over them. I love your education and your approach in really making it the best for the person in front of you. So thank you for that work that you do. I know you're just helping so many women and it's something that's sorely lacking in the medical system. So thank you.
And I love like likewise, admiration is just mutual and I just gravitate towards your posts, especially because you just really get in the weeds of like the nuances like you referenced earlier, but it's more than that. It's individuality. It's the person behind the numbers. Like you really understand the emotional component of all of this in a very like empathetic way and way that also is solution oriented, like as far as getting answers and hope in a real way.
Yeah.
And you're not selling just this supplement, this, I don't know, add-on package or whatever. It's more of like, no, your problem is that everyone's selling you everything and it's time to look at you and all about you. It's about you and who you are and optimizing your life and using this as an opportunity. I think it's very much about like, let's use this as an opportunity to heal. You deserve joy now. I think we share a lot of that in common. And I think that's why we gravitated towards each other because, I mean, we use science and we aren't ever going to say, oh, this one number defines you. This one disease defines you.
Yeah. Well, I appreciate that. I mean, it is such an honor, I think, working this space. And it is about individuality, nuance. I've started to say it lately more because it's just like social media is kind of this double-edged sword, right? For so many of us, it's like we want to get to the mass, we want to teach people and educate people, but social media sells certainties and nothing about fertility is certainty. Everything is nuance. Everything is, a yes and or a yes but, and well, it worked for this person, but not for this person. And so, showing up there is a lot, and I appreciate everything you just said there. So that means a lot. And talking about, not being certainties, I just want to start off about this one stat that I'm sure a lot of people are familiar with, but the fact that it takes a woman about 10 years to get diagnosed with endometriosis, right? I mean, that's kind of like where we're starting at in the system. I want to really give information today that cuts that down for women getting answers. Clearly, that's a huge barrier in women getting and staying pregnant, especially if we're starting our families later in life too. I feel like obviously then, 10 years is different when you're starting at 35 than if you're starting at 25. And the pressure feels more prevalent. And then they get that from the standard care as well, pressuring that timeline and IVF and all the things. So I'm going to give you kind of like 3 things I hear from my clients. And I would just love for you to share immediately what comes to your brain and see where the conversation takes us. All right. So number 1, if you're not in pain, you don't have endo.
False.
Thank you. That's all we need to say, right? That is the answer. False.
Unfortunately, false, I guess. That's oversimplifying the disease and it's showing, just how there's so much misinformation that's pervasive. Endometriosis presents to me either as pain or infertility. Sometimes both.
I learned this from you. And I don't mean to interrupt you, but you said before that infertility in about 60, maybe even more % of women is the only sign of endometriosis. Is that correct?
I would say that's the main drive. I mean, that's a nuanced answer. Okay. So let's just say the main driver of what gets them in the doors of a doctor's office, right? Because there's so many women in pain and they're like, well, that's normal and that's
Mhm.
subjective and blah, blah, blah. Or my mom had it, so it's fine. Or it's not as bad as my friend that's throwing up. So pain in my population of women is less common than infertility for when they come to see me because usually they've belittled their pain, to be honest. They've normalized
Mhm.
it to themselves. They've gaslit themselves after being gaslit by the system or what their expectations were of their mom or themselves or whatever. So um yeah. So again, the answer is nuanced.
Yeah.
But infertility is a huge, huge red flag for endometriosis
Yeah.
potential.
And we'll get more into that. But what about this other one that I hear? I hear this all the time from standard allopathic practitioners who are telling women that, okay, so you might have endometriosis, but it doesn't impact your fertility.
False. Misinformation again. I mean, there's so much data to prove. Even mild endometriosis is a risk factor for infertility.
So they're saying egg quality has nothing to do with egg quality. That
So, there's chronic inflammation in the pelvic environment, and this chronic inflammation is like a smoldering fire or lava around. That's what I imagine in my brain. I don't know. That's my analogy in my like smoldering. And so that's toxic to whatever's nearby, the lining of the uterus, the tubes sometimes,
mm-hmm.
the ovaries. And so what does this do? This impairs um, ovulation sometimes, egg quality because of chronic inflammation. Chronic inflammation depletes everything, like nutrients and all that, and causes the ovaries to age quicker. And if the ovaries age quicker, they're going to be firmer and have more difficulty ovulating as well. There's recent data on that that's really cool that I went down that rabbit hole. It was really amazing. So conception is impaired as well. Transport of even sperm, they
Mm-hmm.
don't like that environment, which is crazy. Even the sperm, okay? So it's sperm
Wow.
and eggs mirror each other, right? Like they are both single cells that are vulnerable to the environment. So if it impairs one, it impairs the other likely too. So sperm don't like it, and just conception, there's difficulty of just the egg and sperm meeting. There's difficulty of the embryo coming back down the tube. Probably the cilia in the tube are likely impaired too, to some degree. Again, that's very difficult to study. And then implantation can be impaired as well because of the inflammatory changes of the lining of the uterus. So every single aspect of fertility can be impacted by endometriosis. It just really depends on so many factors that we don't totally understand, but it absolutely can.
Yeah.
Is the
Yeah.
answer.
Yeah, thanks for breaking that down. I think those two, just calling them out right out of the gate, is very important because we know so many women are told this, and they have this, this struggle with that in the beginning of even just understanding which direction, how to approach this. And many often are just also told, well, even if you have it, again, it doesn't impact fertility, which obviously we just kind of broke down, but also that endometriosis doesn't impact IVF outcomes. So just do IVF. Clearly, with that information you just shared, we can, yeah, it's a crossover there. And IVF is not a great solution. Let's talk a little bit about this. I mean, again, we could do a whole hours long conversation with this, but in general, if somebody is told that, well, IVF will kind of, it doesn't matter, let's just do IVF. What should we be thinking about instead?
Yeah, I mean, first, why doesn't it matter? Okay, I think to the patient it matters if you have endometriosis. That is a quality of life issue. Let's say you're more than your reproductive choices, right? So you're worth more than just putting a baby in your uterus, right? So you're more than your reproductive capacity. You're worthy of knowing if you have this disease or if there's a high suspicion and what that disease is and how that could impact your life directly towards fertility or outside of fertility because it is such a chronic severe disease that does impact quality of life in majority of cases to some degree. Whether you realize that or not is an issue.
Yep.
Then yeah, does it impact IVF? Absolutely it does. It absolutely does. If you look at data of women who know they have endometriosis and do IVF, it's worse. You're going to have worse outcomes for all the things that I said because the disease is there.
Exactly.
And guess what? It's probably even more inflamed when you throw really high dose estrogen. Why? It's because endometriosis is similar to lining of the uterus, which is responsive to estrogen. So when you're pumping the body full of high dose hormones way beyond what's normal, women are not really ever supposed to be exposed to levels of estrogen in of 1,000 to 4,000 plus. What typically max for a day is 400 when I monitor natural cycles. So that has an impact of inflammation. So it's going to worsen inflammation. It could worsen the disease. Plus, you're poking around with needles to disease that could be in the ovaries, which could cause bleeding and spread of the disease as well. So, and scar tissue. So, my concern is that natural fertility is almost definitely worsened by IVF in many cases. And whenever it hurts natural fertility, it's going to hurt IVF outcomes as well. They overlap. They're not in their own bubble. IVF works within the human body. It's not immune to the body's needs, right? Just because one aspect you take conception out of the body, once you bring it, well, it's impacted by the conditions outside the body, and then it's also impacted by the conditions within the body. But the question is, why is that so pervasive? I mean, I would say the doctors who do IVF aren't really trained in endometriosis. And so it's possible they've missed a lot of cases or they've read something like the other misinformation or they were taught misinformation, old school information. But all they're one trick pony, mainly IVF. And so and you're biased towards your tool, right? Like if you have a hammer, everything's a nail. So you're biased towards your tools and you've seen it work. So you probably remember, like have recollection bias, probably haven't read the literature. And people leave, right? So you have more bias. So if those patients probably leave and go somewhere else, and those patients usually come to me. So after 4 to plus 4, 5, 6 doctors have missed it. And so, yeah, and of course, so that's my bias too. I get some of the failures of that. And so perhaps I get some of the worst cases as well. But basically, we have a lot of miseducation in medical school and pervasive misinformation about endometriosis and women's health in our medical school, OB/GYN residency, and I assume REI IVF fellowships.
I want to talk about, I've had clients, you mentioned how it can flare endo, right? When we don't explore this, we don't, not necessarily even excise or going for surgery, but we don't manage it. We don't support it with lowering that inflammation. We don't support it with addressing gut dysbiosis. We don't support it with environmental toxin, estrogen metabolism, anything. We just do IVF. And these women have serious symptoms, flares. They are thrown off for future cycles, sometimes 6 months after this really poor tolerance of these estrogen medications, like you said, that are given at 1,000 to, I think, 4,000 times what they should be. That is a problem. I mean, when we just ignore this, even if a doctor in IVF, yes, that's their specialty, that's their bias, right? They go to that. They don't have other tools in their toolbox. But my question is, shouldn't we be doing a little bit more thorough evaluation of a client, of a woman, before she says, just do IVF?
Absolutely, right? It's never just IVF. And it's never, I mean, infertility is never just solved with a baby. And anyway, no matter how you slice it, like even adoption, obviously no one's like, oh, just do adoption. That doesn't solve the underlying issue, right? Women and couples deserve answers and to know there's a medical problem. They shouldn't have to blame themselves in the process. That's just a natural thing that happens when you don't have answers. And so they deserve to feel better and prepare their body to be even better parents and to enjoy parenthood better. So it's an opportunity to feel better. Something is wrong. And that is all possible. Yeah, I mean, most people don't hit such an obstacle. But also, like, people, there is such a beauty in being so prepared to be a parent too, right? Like, I mean, to feel better and enjoy your kids, to realize how you can overcome even the hardest obstacles. I mean, imagine like, I mean, nighttime wake ups for someone that is not mentally prepared versus someone who is, for example, with this child, and being able to really enjoy that moment and live within that moment with that child. What a gift it is to that child to prep your body, to prep your mental state, so just, doing adoption, just doing IVF, let's say if it did work, which the problem is it doesn't really work that way more often than not. But even if it does work, uh, as far as one outcome, you're missing all of these other things that have led to that point. And then you're going to be busy, you're not going to do self-care. So if you don't do self-care now, you're never going to get to it. So it's a beautiful opportunity. You can't see that right now because you're like running towards this outcome. But if you take a step back and look at the big picture, let's imagine, like, keep that hope that that baby's going to be there. And like in a perfect world, you can be so prepared, both have a really healthy, prepared body, mind, and soul for this. And I mean, that can be a gift, an opportunity that you give to your future child, is investing in yourself.
I love how you're putting that. And there's so many things too we know, even without a diagnosis. Okay, so yes, PCOS, endometriosis, addressing that diagnosis before we get pregnant can help us tremendously with obviously our health during pregnancy, even though reduces pregnancy complications. I mean, you name it, morning sickness, gestational diabetes, all the things during pregnancy, delivery, and then also postpartum.
Absolutely. And then forever after that.
And
Right?
then right, and then your children too, like, and then giving that to your children
are going to be less likely to have PCOS, for example, if you address PCOS.
Transgenerational health really starts with what we can do now. And I think so many people, like you said, we miss out. Of course, we get the blinders on of just getting that baby, and that's the end goal. We work so hard to remove those blinders and redefine success, what it means to be successful outside of just a positive pregnancy test. And that is the power of it. That is what I really would love people to understand. And it comes from this education, right? Which we're both here talking about right now. So it can be so beautiful. So another question, kind of just to go back on, those women who unfortunately have a very negative experience with IVF, whether they have that is because of endometriosis or other underlying factors that haven't been addressed. Are there, like, what are your top red flags when you might think of that? Like maybe somebody not tolerating stims well in IVF. Are they your classic endo symptoms that go undiagnosed or unrecognized? Or are there like other big ones where if somebody's talking to you in your office and they're getting pressure to do IVF, but you're looking at them, you're looking at that story and you're like, wait a minute, these are some red flags. What would those be for you?
Yeah. Wow. I would say, I mean, really, you need to know your diagnosis before you do IVF, right? Like first, you should really be convinced that you need it, and you should really feel like at peace about it. So if you don't feel at peace, don't even walk in those doors, because that's just their product. So really being at peace with it. If you're not, don't go in those doors. If you don't have an answer, don't go in those doors. Get a workup before. And so I would say, gosh, yeah, we could go down different. Gosh, there's so many. I mean, depends on the diagnosis, but like, I mean, let's just go through diagnosis issues that we will find with IVF, because I think, yeah. Okay. So
well, it reminds me of your symptom survey too, Dr. Whittaker, of like really starting there. I mean, that's such a powerful tool that we've given to so many of the women that we work with, of understanding those symptoms, because you said it too. And this is another thing that's such a problem is women they've been gaslit for years on their symptoms. So then they gaslight themselves, and their pain of a 10 for anybody else is a 2 or 3 for them.
right.
So actually just maybe even those symptoms, like that as a red flag of,
Absolutely.
yeah.
Yeah, so let's talk. Okay, so we can do both symptoms and so 3-tier endometriosis self-survey that includes pain, including when you were a teenager, pain and you were
Mhm.
missing school, vomiting, or just bedridden, or ever curled in the fetal position. That's a very like specific to endometriosis. All of those would worry me that you could flare endometriosis, worsen disease, and have a worse outcome. Um, Also, tail and brown bleeding, I put that in the survey as well, could be a sign of inflammation in the lining of the uterus, and it could be related to endometriosis or another cause of infection or inflammation, such as infection, like chronic endometritis. What happens when you implant an embryo into an infected uterus? You lose the pregnancy early, or you end up showing an infection and losing the baby in the second trimester, or you get septic, like very sick. That's more rare. Those are all more common being implantation failure, followed by then increased risk of first trimester miscarriage, then increased risk of second or third trimester miscarriage or loss. But also, you could get very sick with that being missed in some severe cases. But chronic endometritis is no joke. An infection of the lining of uterus, super common, super, super, super common. Oftentimes it's milder, wouldn't cause like the worst case scenario, but there women I find 3 different infections in the lining of the uterus, and sometimes infertility is our only symptom, and or tail and brown bleeding, especially 2, 3+ days more at the end of the period, where it really you should have a pretty clean break from
Mhm.
bleeding, maybe 1 day of brown, but after that, it's a little concerning.
Yeah. Yeah. Those are really great and ones that aren't talked about. And even, this is seeing the whole person, right? I mean, how many times is a physician in the allopathic model going to look back at your teenage period health? you know?
Yeah, and infection, they aren't looking for infection, even though it's low-hanging fruit. You swab the lining of the uterus or fertilizes or whatever. I mean, a lot of this stuff you can figure out on your own. Your doctor's not. I mean, I think the key thing is you are in the driver's seat of your health. Like, no one doctor is probably going to do all the workup that's needed. There's very few of us that like kind of see all that. And so having a multidisciplinary team of like, what you do and me or whatever, like, a team that's getting different angles and aspects for a puzzle piece. But you are in the driver's seat. You're going to be able to find the team. Like there's no one perfect team for everyone. One other diagnosis, PCOS, actually is very much flared by, that's the worst, probably, I don't know which one's worse, PCOS or endometriosis for IVF, because, well, PCOS is not a diagnosis that should do IVF. I've seen an IVF doctor admit that. They're going to be overstimulated. All PCOS patients have a high AMH. And so what that means is they're going to have an overabundance of stimulation when it comes to these drugs. And so they all get some degree of ovarian hyperstimulation syndrome.
Wow.
And so then, like you said, their PCOS is actually worsened. I've seen it on paper for 6+ months.
Mm-hmm. Mm-hmm.
And so their
Yep.
cycles are made worse. Like, and so here you're worsening the disease, potentially worsening their testosterone, worsening all these things. And so you're putting, and again, because of inflammation, PCOS is inflammation driven. And so then you're supposed to put embryos in the body while it's actively inflamed. And then I'm worried about the children too, that
Right.
that environment. But there's really not a need. That's not a diagnosis that you need IVF for. That just means you need to help them address their PCOS drivers and help them ovulate. So is it driven by insulin? That's a beautiful fix. And again,
Yep.
not only are we worried about the inflammation in the environment from the ovarian hyperstimulation, but what about the insulin that's going to lead to gestational diabetes? That's going to also, again, increase the risk of serious pregnancy complications, like very serious ones, depending on, you know, what the state, what the support and the education of the mother is.
And we see so many other factors in these diagnoses: hypothyroidism,
Oh yeah.
autoimmunity. I mean, even as simple as like nutrient deficiencies, gut health, right? I mean, all these are overlapping, and it really is. I mean, just talking about thyroid and the subclinical thyroid, right? That is never really addressed, and then the autoimmune piece of it is I hardly ever see somebody come in with antibodies tested for. And we see a huge connection of that with miscarriage in the
Oh,
first couple of days. I mean, there's a huge draw on the thyroid in those first couple of weeks. You come in with a subclinical thyroid issue and then wonder why you keep having early losses. And it's just like you're saying, the pieces, it might seem like these pieces are just scattered all over the place, but when you work with people who truly see the connection and are able to pull those together, it does what you just said is the most important thing. And maybe the number one red flag is when you don't feel like you're in the driver's seat and you don't feel like you have that understanding of your own body, your own health, your own story to then go in and actually help advocate rather than being told what to do and feeling completely out of control of your story.
Yeah.
No, it's huge. It's just huge. And that's unfortunately, I mean, and so talking about restorative reproductive medicine, I mean, if somebody's ever heard this term, I kind of, I think this is a great place to talk about it because we're really talking about two different options, two different menus, two different pipelines. So we have the standard allopathic model, and then we have restorative reproductive medicine. I don't love separating them and kind of like driving this wedge between them because I think that's what we're maybe being told to do and picking a side. And so I just want to deconstruct that right away, but it's not one or the other. It's really both. But tell us a little bit about RRM and what that is and how that looks different than the standard model, which I think most of us are familiar with.
Yeah, I mean, it's what I think medicine is supposed to be, finding the answers and treating the problems.
Wow, mind blowing.
I know, but it had to be given a name because it's so countercultural when it comes especially to women's health.
Yeah, which is sad.
It's really
And
sad.
it's very sad that, and I don't want to get into this because I know that this can get very cynical very quickly, but about how women are told that RM is basically a faulty way of thinking about medicine, and that is a disservice to women's health.
Right. Yeah. I mean, there's a lot of money and propaganda out there for to go against what good medicine is, and just that's a huge red flag. And it's important that if you're educated, hopefully you'll see through it. And yeah, we like people like me. I'm just trying to educate what proper science is, and it's just I don't know. It's an interesting time. It's just an
Yeah.
interesting time to see that, and yeah, I think the more you're educated, the more you do your own research, the more you just believe in your body, believe in yourself. Um, I think it's very easy to kind of debunk those kind of claims that whenever you see these posts or guidelines that are published, if you read into it and you do fact checks, they're all easily debunked. So I invite anyone to do that and just really look at the data. Go to the data. rmacademy.org/library has tons of articles, directly accessible research articles, so you can find the data for yourself. I like to use Perplexity AI, and I put a question in there, and it helped link to articles directly as well. So it's all out there. It's hard to find people you trust in this space because so many people do take advantage of people in hard times, and infertility is the hardest. So there's a lot out there that's wrong and predatory. Unfortunately, medicine is not immune from that.
Yeah. Yeah. And so actually let's talk a little bit about, the blend. Yes, we want to support all these things we talk about, inflammation, gut dysbiosis, the immune piece of this, right? That is this multifaceted approach to endometriosis. But then say, okay, it's time, been on this journey for multiple years, you're just completely burnt out. Quality of life is still suffering and you want to have excision surgery. I've had, unfortunately, this, again, resistance where women go and practitioners say, no, we don't do that anymore because that is damaging to someone's fertility. You want to do medication to suppress that. So let's and there's all sorts of approaches with that may or may not be helpful. But when someone hears that, what is the actual other side of the story to that?
First, is there any data to support that medication supports fertility? I really have a hard time finding any. And if it was true, we would know, right? There's a lot of money behind these medications. And so if there was a magic pill, we would know by now. There is no magic pill, and I don't think a magic pill is coming. So there's that. So there's a red flag that we know, oh, something's off with this advice, right? Now, damaging fertility. I mean, technically, any procedure has risk. Absolutely. But what does it depend on for surgery? It depends on so many things, including the person doing the surgery and how they're trained and what they're doing. Most surgeons are actually not trained for fertility preservation or enhancement, right? Most of them, unfortunately, with the way that the history of medicine developed in gynecology, fertility went one track, IVF only, pain, gyn, and pain was another track. And so most surgeons are focused on improving pelvic pain. There's very few of us that are like, oh, wait, here, we're in the middle of corrective surgery for infertility. We're a very rare breed because bridging that gap.
Yeah.
And so things that we do include using a laser, delicate tissue handling, reconstructing organs a specific way, adhesion prevention, for example. And so with these techniques, overwhelmingly, women are better than they walked in the door with this disease. There are risks always, and that is increased with the severity of the disease. So those are the worst cases where the ovaries are on the brink of imploding from endometriosis. I don't know. That's one way of saying it, but the ovaries are being engulfed with the disease. Are they going to respond to IVF? Probably not. Are they and could it spread the disease? Yes. So in those cases, I don't think IVF is better. You're going to get bad eggs and the embryos won't make it. On the other hand, should you try surgery, which at that point is important for health reasons because the disease could spread and cause some serious organ damage, for example, and pain. Could your ovaries shorten their life expectancy by 6 months from that? Yes, it could happen because they were so fragile to begin with. So I have had a very small percentage of women, I mean, probably 0.2% of women that it does push them over the brink. Okay, one was 46 and her ovaries were imploded. And another, I mean, you never know. It's just, and then one was getting worse, her ovarian function, but she conceived. Like these are just very, very challenging cases.
Right.
Other times, like I found a cancer once, and then of course that's, got to remove an ovary for that. And, it depends on the case, but it's a misleading statement, I would say.
You have a whole class on this, right? Your master class in excision surgery. Is that what's titled, or?
It's how to screen an endometriosis surgeon for fertility purposes mainly. And so you can vet anyone for yourself to see how adept they are to how fertility minded are they. Because that's unfortunately a unique perspective to bring to surgery and to screen your surgeon. Are they thorough? It also helps with screening an excision surgeon. So if you're not fertility minded, at least you'll be educated enough on, okay, well, I guess it doesn't count for your audience, but if you're telling a friend, you can still screen for excision. So treating the disease like a cancer and giving it the respect that it deserves to be able to get a good outcome of surgery if it's for pain.
And most standard OBs are not going to maybe be the right person to go to for this.
Most likely not. Again, I'm like, you can screen them. I've had people find it close to them when they're on my wait list. I had one find one close and get a really good surgery. I've had women fly to India for a similar surgery because I have a wait list. And so I had a very good surgery just from the education that I share. Like, I hope you find that, but it's not very common. That most OBGYNs just don't get the right training. And we typically get a lot of misinformation in medical school and residency. Unfortunately, I had to de-influence myself. I joke that this year I'm de-influencing myself more, but I had to kind of undo a lot of the misinformation that I was taught in my medical training to try to figure out this disease. And social media was very helpful with that, actually.
Yeah, beautiful. So tell me, whenever somebody is going for, I see this on social media right now. They're like, I'm going for my surgery. What does that tell us about the 1 through 4 excision surgeries that maybe they've had?
Probably wasn't excision. Probably wasn't thorough. So It's really important. Again, this is one of the screening techniques. Vet your surgeon to see if they follow a map of the abdomen and pelvis. Are they looking at the diaphragm? Are they looking at the appendix? Are they looking under the ovaries? Are they looking everywhere, leaving no rock unturned to find it? Are they trained in visualizing all appearances of endometriosis? Probably not. It's not just black. It also can be clear. So you can imagine how hard that is to an untrained eye to find.
Sure.
And then they may not have cut it all out. So they might have left some on purpose because they were afraid, or they may have just burned the surface instead of cutting it out at its root. And so I just see the first four surgeries were most likely incomplete. Are there cases of true recurrence after very severe disease? Absolutely. That's about 15% of the time. But typically on a repeat surgery, the disease has been improved and it's an easier surgery. And if you do fertility enhancing techniques, the organs most of the time are preserved. And so it's easier each time and fertility is not harmed. But it all depends. I say no surgery is better than a bad surgery because
Mm-hmm.
you walk away with more damage technically. But a lot of that it depends on surgeon and what this surgeon is working with, whether a very messy canvas or a cleaner canvas to begin with.
Yeah. I think a lot of, you know, I see a lot of great education, a lot of talk around proper excision surgery. You have a lot of great resources on this, having people find a good provider for that. Is that through RM Academy? And also you have on your website, I believe, helping them find providers. Is that correct?
So under highlights, I have some
Highlight.
information. Yeah, I
Okay,
don't like
fantastic.
lists though because I think it's kind of paternalistic and you never know really what's going on in the OR. So I really like that face-to-face meeting with your doctor. And that gut feeling is important too. Like you said, like, is this surgeon driving me or am I in the driver's seat of this? Are they
Yep, yep.
telling me I need it? I always say, you'll know when you need it. You'll be at peace, and I'm not here to convince you to have surgery.
Love
If you
that.
don't want it, totally fine.
I love
So
that.
it's really important to I think it's really important just to sit one-on-one with the surgeon and vet them and know what you should ask and why for your case. And so
Mm-hmm.
that's just through research. No one's going to give you like my course isn't perfect, and of course I'm always changing. I'm like I
Yep.
should I should redo some parts of it, when I have time. But with things that I've learned since I've made it, since I'm always learning. So there's no perfect course for you.
Sure.
Um, there's no perfect outline except what you make.
Yeah. Yeah. Now I want to do some rapid fire. If I look at the beginning, I think there's just so much I would like to get in, but obviously we don't have hours and hours to discuss it. I wish we did. Tell me a little bit about chocolate cysts. Rapid
Chocolate
fire on
chips.
chocolate
Yeah.
chocolate cysts. This is something that women get a lot of confusion about. So they're like told they have it, but they're like, well, what is that? Is this the same as an endometrioma? What do I do about it?
Yes, it's the
Let's
same
talk.
as endometrioma. It's visualized on ultrasounds. They typically are 2 centimeters or more because sometimes you can have additional ones that don't show up. But at that point, it's likely stage 4 endometriosis. And those are the ones I do say really surgery is the only way to get rid of it. And once you have endometriomas, they can rupture and spread the disease worse. So at that point, that's when I do worry about the the disease progression becoming more rapid. Like if you're stage 1, 2, you can wait like even 5 years, I think. Not that I recommend it, but before major damage, you could wait a lot longer. And, I worry that even 3, 6, 12 months might cause one to rupture. Again, it depends on the case and it depends on, are you going to the ER? And feeling things burst inside, like that's a sign that endometriomas could be rupturing, for example. So, yeah, that is more serious as far as disease for endometriosis and I would be more likely to recommend more urgent surgery. Not emergent, but
Yep, very helpful. Now we're talking about the team. There's no perfect team. Different modalities coming in and really just trying to bring in whatever is best for that person. Reproductive immunology. Do you see this being a great part of the team?
yes, depends on who. But I really like Dr. Kwok Kim's team and everyone she trained. There's Dr. Hubis in Florida. Love them. They really work well, like with someone like me that supports natural fertility. They're very supportive of not being the main driver, not saying, well, you have to do IVF or you have to do this. And I've had patients give them a hard time, like, I'm not doing this one part of the protocol. And they'll be very respectful. So and they're so like in depth as far as the workup. And the outcomes have been really good as far as very difficult cases have been able to conceive. I had one patient with over 20 miscarriages that failed all my stuff. And so that's when I really was impressed with them. And I really consider so I'll bring up reproductive immunology, maybe even early in recurrent miscarriage cases or patients that have evidence of immune system dysfunction or lupus antibodies or something. I have a friend slash patient who we talked about it and she's like, I'm going to do it. And I've been very impressed with just the counseling that the education they've gotten and the testing that I don't even know how to do, like natural killer cells. I have no idea. So basically, if someone has had 5 or more miscarriages, I'm like, you really you have no business just coming to me. You need reproductive immunology. I would say 3 to 5, really depends on what they've got done before. Have they optimized their DHEA? Have they supported their progesterone and estradiol and all that? Depends on what are their antibodies, what are their problems, like what have we found and what have we done? 3 to 5, I do often will talk about it, but I'm really worried if you have 5 or more, and especially if you've gotten supportive therapies with me, for example, progesterone support and all the things I mentioned, then I do really encourage talking to them. Yeah. So they're very valuable.
Amazing. And then my last question is ovulation pain. Is this something you see common with endometriosis, or are there other sources of this or reasons for this?
Gosh, that's a hard one, right? Because cause and effect, how do we study that? It's a red flag for endo. Yes. I think, due to the prostaglandin inflammation and the pelvis, you feel things more than usual. You have all those chemicals floating around. So I would say yes, it could be pelvic floor dysfunction, histamine, other things going on too. So I guess it depends on what you do about it. I do think it could be, I think nervous system support would be a good thing to start with, and maybe pelvic floor physical therapy to consider as far as, okay, really being in tune with your body, what else is going on? Just that alone is not going to be just like AMH. There's no one test to be this equals that. We don't have that. No. That is part of the big picture. Do you have that? And you have pain after intercourse. Okay. My brain's going to go towards endometriosis. Do you have that and more I don't know, you're running around all the time and you're not eating and you have PMS, maybe I might think more nervous system inflammation from that, and maybe more just deep breathing and journaling and all that kind of stuff. And I know, or low dose naltrexone, even I like that, but that's more medication. But so it just, again, it goes with just that gut that you go down that path, kind of it's really important to follow your intuition and your gut. I'm learning that more and more, which is so funny, right? That's so counter. Well, I was taught in med school, symptoms are a problem, shut them down. That is an allopathic problem, I would say, versus symptoms are an opportunity. Let's lean into them. What is your body? Your body's trying to help you. It's trying to tell you something. I'm learning more and more what that looks. I'm learning more and more what that looks like, because I honestly did not comprehend that until I'm still learning. What does that mean?
Well, that's what I appreciate so much about you is you're still learning. We should also be learning, and really kind of, I think, reject this idea of getting put in a box and just being, well, here we go. This is you. This is your course of action, especially when we as women do have that gut feeling, that intuition that we have not been taught to listen to, but it's there and we feel it and we know something's off, and using those symptoms as an opportunity to really break out of that black and white thinking. I've kind of always thought this was a bad thing of my personality, but now I'm understanding I really love this as my personality. I coined myself a gray person because I am so anti, like I cannot think in black and white anymore. And sometimes it makes it really hard to, take a position or like, yes, this is what I believe in. That is the end all be all. And I thought that was a really bad thing, but I'm learning now that I actually really love it, and it's I think a skill that I admire in you as well. And just having that time for the nuance, the questions, the outside of that diagnosis thinking. So I so much appreciate that about that you just shared with us, and I know so many women will learn from that, and I think use that as that forward momentum for them. So thank you for that.
But I hope so. I hope it brings hope and light and joy to this season of waiting and in the in between. And yeah, it's important to also just, yeah, find resources of calm in this time and peace, because we always as humans will get thrown into the extremes,
Mm-hmm.
especially in times of chaos,
Mm-hmm.
difficult seasons, and it is part of the trauma response. And social media loves that. Social media makes money off of that. And so it's important to say, oh my gosh, I am doing extreme thinking right now. Like I'm 10 step, you don't need to know your whole roadmap right now. You don't need to have all the lists checked off. That's that extreme thinking that is a reaction to a difficult situation. And so, yeah, sitting in peace and gratitude and joy and nourishing yourself in this moment and finding sources of peace and light just like this, like hopefully this can be for you. I hope uh, hopefully this can help your day today and your path forward, just being here with us. So thanks for having me and spending
Amazing.
time with me, really.
Thank you. Thank you. Thank you so much. And I hope you have a fantastic day.